Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. We're here at the Ai4 Conference, and we're here with Vincent J. He's assistant professor at NYU School of Medicine. Welcome, Vincent.
Thanks for having me.
Yeah, so I'm excited to learn about AI in healthcare. I mean, people love to talk about it, but you're doing some practical research on it. So tell us a little bit about yourself and your work.
Yeah, so I am an assistant professor in population health at GNS Center for Innovation. And I also have a sort of IT role where I lead efforts to integrate AI into the EHR. There's some very technical aspects of that which we can get into.
Sure.
There's also sort of just doing what we can do and making the most of it, which is really fun.
Yeah, absolutely. So where are we really seeing AI, machine learning, all of those categories, analytics, impacting care?
Yeah, so at NYU, we have AI models that are starting to touch almost every major application in our Epic system. I think in the last couple of years, we've seen some really great work where we're targeting nurses in a variety of ways. I think one that comes to mind is one of the COVID models that we went live with. This is a real-time model, runs in Epic. And it was sort of to supplement with maybe the goal of replacing a tool that was developed by nurses at one of our campuses. It's basically a 1 to 13 scale based on what kind of care that patient is needing, and it allows the nurses to communicate within each other to their colleagues about how ill is this patient right now.
Okay.
But by only taking in a few different variables, it can only be so powerful.
Sure.
And so by making an AI model to do a very sort of similar task, we can describe patients basically on a sort of a color scale, and with a number attached, and that can be used as well to sort of prioritize how many nurses are on that day, how you prioritize the process of handing off when one nurse is leaving for the day and another is coming. Giving a little bit of extra attention to some of those higher risk patients. And it's not always that the patients that are the most ill right now, it's the ones that are sort of in the middle that really could decline in the coming 12 hours or so. And another nurse one that's really cool, we went live with this earlier this year. We have, through Epic, something called My Chart, which is the patient portal. And lots of patients send messages in. They think they're sending them to the doctor, but they actually, a lot of them end up at basically a call center.
Right.
So there's these very large pools of messages, like a giant shared inbox.
Yeah.
And there's a team of RNs that actually work those messages, triage them, and then sort of delegate them into different other pools to be worked. And one of the main things that we wanted to target, that was sort of our pilot, was the messages that require an immediate callback. So something in the message that was really worrisome, like chest pain, or something that was really time sensitive. And so basically what we do is, when the model runs, a score is made, and typically the nurses triage the first pool in the order in which the messages arrive. So old messages are the next to be done. So we float those high acuity ones to the top, make sure that a nurse sees them. If they agree that they need to call that patient, that callback happens, much more quickly than normal.
Very interesting. Now you mentioned real time. Like how real time are we? Is this all embedded in the Epic system, or do you have to batch the data from other sources, or how real time are we really today?
Yeah, so Epic has a lot of data that is available in real time, but it can be a bit more difficult to get. There are things like you can do reporting workbench reports, and so the Epic product that allows for AI models to run in the cloud is called Nebula. And one of the ways that you can do that is by basically providing a reporting workbench report, which can be run whenever and however often you want it. And then that data is basically sent up into the cloud as a payload. The model runs, the scores come back. So if you can get your inputs to the model in that kind of reporting workbench report, we can do things in real time. The standard way is you batch that report, you schedule it, say every 15 minutes or 30 minutes. That's what we did for the COVID models we worked on. But depending on what the use case is, there are actually sort of trigger points. So as soon as an action is taken, say an order is signed, or a patient is admitted, for example, or moved around in the ED, there's a little sort of like a little function that runs, it's called an extension, that then runs the model for that one patient right then.
Gotcha.
So that's about as real time as you can get. So we've done a couple of those, which is one for the in-basket messages I was just describing, and we're also working on one right now in the ED. So as soon as triage is marked complete, you know, boom, the score is made, which is really cool. If you can't get your data in that shape, you know, because it's fundamentally it's a report, it's a table. You know, there are character limits, so you can't have like long clinical notes, for example. It's also really hard if you want to do like, give me the last year of this patient's history, like all the diagnosis codes, or all of the different A1Cs that this patient's had, right? That kind of time series stuff. It doesn't really fit that, you know, tabular representation. So if we need to do anything like that, we end up doing our implementation outside of Epic. So sometimes that's an allowable sort of delay in real time. Say we wait until the next day at an 8 or 9. That allows us to use other Epic databases like Clarity or Caboodle that are updated every night.
Gotcha.
And it's way easier to run SQL to say, you know, get me all these labs.
Yep, absolutely.
So that's a big trade-off, and I think part of my role here, you know, because there's a big team of data scientists in the team that I'm part of, the predictive analytics unit. Having a few people in the team know how we can implement things helps us steer the whole team towards, let's make sure we're not going down a path that we can't implement. You know, if the stakeholders say this needs to be real time, or say hourly at the at the slowest, there's just certain data we can't get that enables that.
Makes sense. So what are the data? I mean, it's not, obviously you have EHR data that we talked about. Are there other data you wish you had? And what do you think are the most common data that are being used in the models you're working on now?
Yeah, so at NYU, we have Epic products for almost everything, which is, as I understand it, a little bit unique. There's a couple of things that we don't use the Epic product, but overall we're Epic everywhere, which makes things a bit simpler. So sort of our bread and butter for data science is patient information. You know, we're talking about vitals, flow sheets, lab results, orders, procedures, clinical notes, radiology notes. That's the sort of core bread and butter stuff. Most of those we can gather at a large scale from databases like Caboodle. We slightly prefer over Clarity, which makes it really easy to, you know, get going on a new project. I think some of the really interesting things that we're brainstorming on is how we can get access to data that comes from sort of auxiliary systems that we use.
Like the ERP or lab systems, or? So
our lab systems is all through Epic,
it's all
so
Epic,
that should be fine.
That's easy for you.
That's relatively easy, right? I was thinking more about like the little devices at the bedside.
Sure.
You know, the medication pumps, the telemetry monitors, even things like EKGs or you know, longer term heart monitors. They are all products that we purchase, and the data. Some of the data becomes available to us that's documented, you know, by the clinical team. Say vitals every hour, every 4 hours. But say the Philips machines, they have the vitals constantly, every minute, right? So I really wish we could tap into that in a way that isn't. It goes to their database, and then we have to work out some kind of licensing agreement to then pull it down. That means we can never get to real time. I've seen some interesting work from other places that basically use some middleware to tap into that stream. It's not something that we're doing right now, but strongly considering.
Interesting. So you did a random clinical trial, which is interesting for an organization like yours to do, right? It was around the COVID-19 protocol. Tell us about that, and what were the results?
Yeah. So I think this is great. This is cradle to grave, the whole thing. I think just a bit of background. I think so. We sit in the Center for Healthcare Innovation and Delivery Science, and so the director of that center, Lera Horowitz, also runs a little group called the Rapid RCT Lab.
Okay.
So they basically provide a function, a service to researchers that want to run small randomized controlled trials. So they help with the planning, the logistics, the registration on clinicaltrials.gov.
Sure.
Helping
IRB.
Exactly. There's a lot of paperwork. And so we worked with them on this, which was really great. And we'd been thinking about it for a long time, like we should really be doing more randomized controlled trials, having a lot more foresight into, okay, so we have a model, how we're going to use it, what's the intervention plan, what do we then expect the impact to be. So with COVID, New York City was one of the first places to have a substantial surge. And so in around the middle of March, we started developing a model, and in only a couple of weeks we had a prototype. A couple more weeks we actually had that prototype implemented into Epic as this kind of cloud-based model. We did some iteration, lots of clinical validation about do these coefficients make sense? Are they pointing in the right direction? All that sort of thing. And we ended up with this nice, simple, linear model that was surprisingly performant. So anyway, because we were starting very fresh and we didn't really have time to go through, say, user testing and things like that.
COVID kind of pushed everything.
Right. So, and COVID also opened a big door that everything we were doing at that time was sort of off-label or experimental, depending on how you cut it. So the AI was really no different. Almost every patient admitted was being considered for some trial or several. And so we were allowed, we had sign off on the research side and also from, say, the chief medical officers. And so at all of our campuses, when the score went live, it was understood that half of the scores would be hidden, and they would be our control group. So the intervention had color-coded scores available, and the control arm didn't. We knew what those scores were behind the scenes, which is a big. Had to make sure they had their audit trail, and so we could actually watch to see what happened to these patients. Our hypothesis was that patients that had a green score that were low risk, the clinical team would see that they're low risk and clinically agree that this patient was doing fairly well, say that they didn't need any significant oxygen required therapy, etc., and they could potentially be discharged. That was the goal. So the shortening length of stay.
Right.
We were under significant surge conditions. We wanted to get people out the door. Yeah. We were hoping that the score would help with that. So we went. The study started May 15th, 2020, and it wrapped up after we enrolled over 1,000 patients. Wow. That was our plan, but we had a very quiet summer in 2020 with COVID.
Yep.
So it really drew things out. And I think it was early December that we reached 1,000.
Okay.
And we had the data reports ready to go. We knew what we were looking for, so just waited for everybody to be discharged, waited for people to be followed up. Ran those reports. The analysis shaked out. So we were.
What'd you find?
So unfortunately, no significant decrease in length of stay after going green, or length of stay overall. Our safety indicators, bad things that could have happened as a result of the score, they were unchanged as well. So it seems like the score being visible definitely didn't have any negative effects, but it also maybe wasn't convincing enough. We've run down a couple of hypotheses, like maybe the model lost its performance over time. Actually have data to suggest that isn't the case. Even into the Delta variant in 2021, the model was still accurate. So I think it's more to do with the sort of last mile thing, like how many providers or clinicians actually knew about the score,
Right.
that were actively searching for it. And we have some anonymized metrics sort of out of the box from Epic about how many people see the score.
Okay.
But we don't really know who those individuals are, when, for which patients, how many times are duplicates. So we're really a little blind about where to continue that outreach.
Yeah.
And I think we did really the best we could at that time, reaching out to different clinical groups, nurses, providers, department heads, things like that this thing existed, it works, we've got the institutional support to use it. I think at that time, we were basically having daily COVID updates.
Yeah.
And even though we pushed really hard, I think it was just in a really busy time, and,
Sure.
and some people were, it slipped through the cracks.
So it could be an issue that, the AI wasn't explainable, right? The score wasn't explainable in a way that a clinician could understand
Yeah.
enough, or maybe they didn't know, okay, if that score is green, then I should do this versus red, I do this. And maybe it's also just the culture of healthcare. We're afraid of liability.
Right. No, I agree. And we did what we could explanation-wise.
Sure.
So there's actually, if you hover over the color-coded score, there's actually a little sort of pop-up bubble that explains the patient's trend line, like if they're
Gotcha.
getting worse, getting
Why
better.
is it green?
And it also explains up to 10 different factors that went into the score. So you could see, say, if their platelets were high or low, if that was a good or a bad thing, as well as their eosinophils, tangible stuff like that to try to surface some of that data. But we don't have any indicator how many times people were using that functionality.
Sure.
And also, if you hover over the column name, you do get a bit of an explanation about what the score was, what it means. If a patient is green, what that actually means, on aggregate.
Exactly.
It means that they're mostly going to be fine. I just don't know if we had, again, it's a really busy time in
Sure.
COVID. I'm not sure people were feeling like they had spare time to try out a new tool.
Yeah, no, that totally makes sense. And a qualitative analysis of that would be interesting.
Yeah.
How did they react? Did it even just give them some comfort during this challenging time, right? Which, I don't know how you measured that in a real study, but, I wonder if that was a factor for them, and maybe gave them oh, they're green, okay, I can stress just a little less on this.
Right. Actually, thanks for that reminder. I wasn't involved in it, but we had some collaborators do basically exactly that. Initially a survey, and then also some user interviews. And what they did find is people that could recall using the tool, they did feel more confident that they sort of had basically a second read. How exactly that manifests into the change in behavior is difficult. I think there's also lots of practical issues. Just because a patient is low risk doesn't mean that they actually have somewhere to go home to. Say if they're still testing positive, they're still infectious, they can't go back to a nursing home.
Sure.
Or they have an elderly parent at home and they just want to stay a couple more days.
Right.
Sort of practical discharge planning, things like that. It's really hard, considering how an AI will work, to actually knock all those things down as well.
Yeah, absolutely. Well, and we all want to decrease length of stay and increase revenue and all sorts of things like that. But these days, our clinicians are so burnt out that, a factor that gives them some comfort, reduces their burnout is a good thing. Now, it's hard to measure, so I think that's the challenge. So let's talk about, what is your process from doing research into something like this, or, any other AI machine learning project you're doing, analytics project. You do the research on your side. How do you push it then into practice, and get it implemented in Epic or whatever system you might be using?
Yeah, so the team that I'm part of, the Predictive Analytics Unit, we handle the development, the validation, and also the actual sort of implementation or deployment piece. So when it comes to sort of what we're working on, we have a wide variety of stakeholders that come to us with ideas, clinical leadership, operational leadership, also, individual, say, nurse leaders, like in the case of that COVID model. And so then we sort of work with them about what's important, how you want this thing to work, what kind of data do you think is important, and we develop our data like that. So that's the sort of practical steps of making the thing. When it comes to deploying, we are sort of the central team that works with whichever app team sort of owns that piece of Epic. So, for example, with COVID, that was inpatient orders. For the MyChart messaging thing I just mentioned, that's our ambulatory.
Okay.
And so those app teams, they are used to building the records out. They're used to building the integration. How users see things, and so we leave that to them as the experts. But the piece in the middle that's sort of common is the predictive model build, and so we actually do that. And so we have Epic access to actually build some of these records ourselves. We upload the model. So it's really great that we can do some of that. And then there's also a sort of a second check from the app team. And because we're a few models into this now, we have local experts that work for an app team, but they also know how these models work. They know what's needed. They can really sort of help train other analysts and expedite things, which is really cool.
Yeah. Well, thanks so much for sharing all those insights and perspectives. I think we all want this to happen, but to hear how much work goes into it, I think we forget how much work there is in researching it, implementing it, rolling it out into the products, changing the culture. Like everyone's like, oh, just apply AI to it, and you're like, it's a little more complex than that. And I think you gave us some good insights and perspectives into that. So thanks so much. Thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks, Vincent.